Now, again your same diagram with the same specifications. This should be more near the endocardia. Now, what is the concept of junctional tachycardia? Junctional tachycardia means that there is something wrong at the junction. It means around or near the AV node. And there is some pathology here which is precipitating tachycardia. Now, how it really happens? Actually, one of the simplest example I can give you is that let's suppose you have a patient and he has abnormal connection between the atrium and ventricle. Now there are one connection or two connections? The one connection is AV nodal connection, other is pathological connection. This pathological connection is called bundle of Kent. What is it called? Bundle of Kent. Have you heard of it? K-E-N-T, right? Bundle of Kent. Some people are born with this anomaly. First we'll talk about the normal ECG, and then we'll talk about why they undergo tachycardias at times. The normal ECG pattern is somewhat like this. When they are not in tachycardia, this wave is the pathological wave. Normally you expect it should go like this, then it should go like this, then it should go like this, right? But why it is turning like that? Is that right? Let me explain. Actually, if current is coming, let's suppose current is coming through this pathway and this is faster pathway, current try to go from anomalous pathway as well as through normal, right? Now, when current will reach through the bundle of Kent here, before reaching to, look here please, this area, concentrate on this area. You know, this is a piece of myocardium which is connecting the bundle of Kent with the fast conduction pathway. Is that right? Right. Now, a bundle of His. Okay, we can make it like that. This is bundle of His. What really happens that because this pathway is faster than AV node, so this straight line becomes shorter. This straight line should have been from here to here, but actually this is short. Why this is short? Because as compared to AV node, this pathway takes the current rapidly. But when current comes from normal pathway, it rapidly enters into very fast conducting system directly. When current comes through AV nodal pathway, it directly enters into highway system, fast system. That is why that in normal person waves come. But here it is first entering into slow system in the muscle, not into Purkinje system, not into bundle of His. So between the bundle of Kent and between the fast conducting system, there is some myocardium which is conducting with moderate speed. Due to that reason, a small vector is made, and this vector, which is concerned with depolarization of some septal muscle, right? This vector which is made for the depolarization of some septal muscle, as current is moving from bundle of Kent to the fast conduction system, it produces a small vector which can lift the needle gradually up. And that is why this particular wave is going like this. But this is the moment, look here please, this is the moment when the current hits the fast conduction system, and then it very rapidly goes up and down. Is that right? Can you recognize this syndrome? You've heard of it. Excellent, excellent. So Rahul is not sleeping in the lecture. So he remembers it is Wolff-Parkinson's White syndrome. Wolff-Parkinson's White syndrome. So this is its classical ECG when tachycardia is not there, when junctional tachycardia is not there. But these patients, if they take coffee or they do some exercise, or they become emotionally excited, or they become worried, anxious, or they take alcohol, or they undergo any phenomenon which make the AV node fast, they precipitate dangerous tachyarrhythmias. Now let me tell you how they can precipitate dangerous junctional tachyarrhythmias. Look here. First, a basic concept. A SA node produces current after how much time? 0.8 second. If your heart rate is, let's suppose your heart rate is 72 per minute, it means the SA node is firing at the rate of 0.8 second. Every 0.8 second, SA node fires. And if every 0.8 second SA node is firing, it means every 0.8 second, of course, AV node will be releasing the current to ventricle. You know, if it fires after every 0.8 second, it means that how many, if 1 minute it is firing 72 times, how many times this will fire? It will also fire at the 72 times. Is that right? Now, let's imagine that you have taken, this patient has taken caffeine, and due to caffeine he develops some irritable focus. Look here. He develops an irritable focus here. This star is showing an irritable focus, right? This is an irritable ectopic focus due to caffeine or due to some other sympathomimetic activity, and it produces an ectopic current. Now, listen here. It is producing an abnormal current, and this pathological current enter into what? Bundle of Kent. And it passes through bundle of Kent, it goes downward, as well as from here it re-enters. But when it re-enters, it finds that this area is again re-excitable, out of refractory period, and it starts rotating like this. If current starts rotating here like this, if this rotation is taking 0.4 second, it means every 0.4 second one cycle will throw an impulse down. And if every 0.4 second one cycle is completed and an impulse is thrown down to the ventricles, it means heart rate will become double than 72, that is 144, and this will become tachycardia. Am I clear? Is it clear, or I should repeat it? Okay, let me tell you again. What really happens, normally, first understand normal. Normally when SA node is controlling the rhythm, when SA node fire, current may go down through both pathways, right? And by the time current reaches, by the time it try to re-enter, current was already coming from AV node as well. So can it re-enter? No. Because when current is passing through some area, that area is refractory for re-entry. That area is resistant to the phenomenon of re-entry. Again, let me repeat. When this person is not under tachycardia, why this person is normally not under tachycardia? The reason being, normally he is in sinus rhythm. When sinus rhythm is there, SA node is firing. When SA node is firing, SA nodal current goes to atria current, and atria gives impulse through bundle of Kent as well as impulse through AV node. And both impulses, wherever they meet, they cannot re-enter into each other's area. Is that right? So it is just like this. A car coming from here and car coming from here, they have to go down, both of them. They cannot re-enter into each other's area. Is that right? Now, if this person develops an irritable focus, and this irritable focus is very near to one of this pathway, either to very near to this or very near to this. So it conducts only through one pathway and does not conduct through other pathway. Then the impulse which is going through one pathway, it may re-enter from the other pathway. And by the time it reaches back at the first point, if this point is still now has become out of refractory period and this point is excitable, re-entry will start. We say that there is re-entrant tachycardia, or we say that there is circus movement. And this movement is completed within 0.4 second. Every 0.4 second, one shot is going down. And ventricles start beating, one ventricular beat every 0.4 second or every 0.3 second, and junctional tachycardia will start. Am I clear to you? Yes, Israel, you are clear? No problem? Or no problema? Okay. Another thing, usually that is why for such patients we say that they should avoid coffee, or they should avoid alcohol, or they should avoid smoking, or preferably if possible they should avoid stresses of life. But I think this is not that easy, right? Anyway, so this was one example how junctional tachycardias are produced. One more example I would love to give you, and in that case, let's take another example of junctional tachycardia. In the second example, what we really see is that there is no bundle of Kent, there is no pathological connection, but within the AV node, listen carefully, within the AV node, two types of pathway are there, right? Listen, that if someone has a problem within the AV node and one pathway conduct fastly, another pathway is conducting slowly, right? Then by chance, sometimes it's possible the current from the fast pathways goes down as well as it re-enter. We say intranodal re-entrant phenomenon. This is not intranodal because it is not within the node, right? But this is intranodal. There is no pathological connection. The defect is within the AV node, that within the AV node there are multiple pathways with different conduction velocities. So one pathway may be fast, other may be slow, and from one pathway when current is going down, it may re-enter through the other pathway. And if this is completing the cycle every 0.3 second, it will start shooting down the currents on the ventricles every 0.3 second, and heart rate will go to the around 180 or 200. Am I clear? So these were examples of junctional tachycardia. Again, how would you treat them? One of the classical method is massaging the, what is it? Carotid sinus. Because when you massage the carotid sinus, that will stimulate strong vagal outflow, right? And that may inhibit the AV node. And if AV node becomes too much inhibited, then naturally it cannot complete the cycle, and the re-entrant phenomenon will break down, and normal sinus rhythm may start again. For example, if you start massaging it, right, then vagus will inhibit this blue tissue, because this is under, AV node is under strong vagal control. When you massage here on the carotid sinus, as I told you, massage unilaterally, not both sides. Because if you massage on both sides, sometimes vagal outflow is so heavy that that may lead to cardiac arrest. So we massage on one side, and if there's a strong vagal impulse, AV node for a short time becomes too much inhibited. So current only passes through one pathway and cannot re-enter, it has to go down. And in this way, a circus movement is broken down, it's melted away. Is that right? Other method is we inject these patients with verapamil, intravenous verapamil, or we give any drug which can inhibit the AV node. Because in these treatment of this is that when there's junctional tachycardia, you have to slow the AV node so much that it becomes so refractory that it does not allow the movement of the circus to be completed. Is it clear? Any question here? No. Now, we have already discussed, yes, sinus arrhythmias. We have already discussed, yes, atrial arrhythmias, and thank God we have finished with the topic of nodal or junctional arrhythmias. Now we are entering into the last variety of arrhythmias, that is ventricular arrhythmias. Ventricular arrhythmias. To understand the concept of ventricular arrhythmias, especially ventricular tachyarrhythmia, first of all we should have a concept that why such tachyarrhythmias occur. One of the common cause of ventricular tachyarrhythmia are irritable foci in the ventricles. That is, sometimes in the ventricle there are some cells which are highly irritable cells, and these irritable cells suddenly start firing in a pathological way. So we have to understand why some ventricular cells become highly irritable, right? Let's draw one ventricular cell here. Suppose this is a ventricular cell and I remove it out, and we will look for electrical activity in this cell. You must be knowing that normally, like all ventricular cells, this cell will be having resting membrane potential. Suppose the resting membrane potential is minus 90 millivolt in this cell, right? And threshold potential is, let's suppose threshold potential is minus 70 millivolt. Now what does it mean? Normally what happens, if this cell is here, and if cell, this is our sample cell, this was a cell which was going to stimulate the next one. Now how this cell can stimulate the other cell is, normally physiologically is, in between them they are having which junctions? The electrical windows in between the cells. What are these electrical windows called? Gap junctions. So normally what happens, if this cell is undergoing depolarization, it will get sodium influx, and some of the sodium from this cell will trickle through gap junction into the next cell. This sodium will trickle into next cell. This sodium will take the resting membrane potential up to threshold, right? First cell loads slight amount of cations into second cell, and second cell's resting membrane potential will go to threshold. As soon as it reaches threshold, voltage gated, which channels open? Sodium channels open. Lot of sodium comes in and it will go under depolarization. Once it is depolarized, remaining story all of you know that voltage gated, which channels are opening? Potassium channels are opening, as well as calcium channels are opening. So what really happens, that this is calcium, right? This red is calcium and this green I'm showing potassium. For some time calcium keeps on coming in, potassium keeps on going out, so cell is gaining cation as well as losing cation, so net cationic balance is not disturbed, and that will produce a plateau phase. But a time will come when further input of calcium will stop, but potassium is effluxing at a very high rate, and when potassium is going very rapidly out, then it will repolarize with loss of potassium. Now this electrical phenomenon which we have seen, that first cell puts some cations, especially sodium, through the gap junction to next cell. The next cell will take resting membrane potential to threshold, voltage gated sodium channels will open, depolarization is there, then calcium input and potassium output together make plateau, and then heavy potassium going out will produce repolarization. Now normally this cell has a very stable membrane property. What I mean by stable membrane property, that once it has come to the resting membrane potential, it will keep on resting. It will not automatically fire. It will keep on resting. It will not jump for nothing. This is a healthy myocardial cell. When again it will go to threshold, when it will only go again to threshold, only when this cell will again trigger some cations. Only then it should go up. Is that right? But sometimes what happens, this cell becomes sick. This cell becomes injured. This cell becomes defective. It becomes dysfunctional and it develops irritability. Now I will tell you how this cell may become irritable. One simple reason may be ischemia. If this cell develops ischemia, it means oxygen supply is more or less. Oxygen supply is less. If oxygen supply is less, one thing which before I go for that, I should tell you here, sodium potassium ATPases are working. What these sodium potassium ATPases are doing? That whatever sodium has come in, these ATPases will take them out. And whatever potassium had gone out, these ATPases will bring in. Is that right? So normally when it is resting, sodium potassium ATPases are working so that during depolarization, whatever sodium came in, it should be thrown out. And during repolarization, whatever potassium came in, it should be brought in, so that balance of the cell should be okay, right? Now you imagine that let's suppose this cell develop ischemia. Because many patients with ischemic heart disease suddenly die due to ventricular arrhythmias. What really happens? Let's suppose this cell develop hypoxia or ischemia. It means oxygen supply is less. If oxygen is less, do you think it will make more ATP or less ATP? Less. If ATP is less, do you think sodium potassium ATP driven pump will work? No. So what really happens? That when there is ischemia or there is hypoxia, then oxygen supply is less, ATP level is less. So when there is low ATP, that will lead to reduced function of, what is this pump? Sodium potassium ATPase. And this will create problem. Why? Because when this pump will not have enough ATP and they will not work properly, then during the depolarization, whatever sodium is coming in, can it go out? No, it means sodium is being trapped into cell. And when cell will develop, trapping the cations, can its resting membrane potential remain much negative? No, if it is not having ATP, its pump is not working, depolarization induced sodium which is coming in, it cannot go out, sodium start accumulating in, this accumulated sodium, right, it will make the resting membrane potential less negative. It means this accumulated sodium will take the resting membrane potential towards threshold. So resting membrane potential will start fluctuating like this due to accumulation of waves of sodium. This is one problem. Second problem, when during ischemia membrane is really injured, physically injured, when myocardial cells are physically injured by ischemia, their membranes become leaky. And you know, normally sodium concentration outside the cell is very high, as well as calcium concentration is very high. So these cations will leak in, and if they leak in, again cation loading. It means ischemia can produce cation loading in two ways. Number one, it can load the cation by slowing the ATPases. Secondly, by simply damaging the membrane, and it cannot prevent the extracellular cation from coming in. This is one way. And of course, whenever cation will be loaded, resting membrane potential will become less negative and it will start fluctuating. Yes. And if during fluctuation, if it touches, by chance, if it touches the threshold, a pathological action potential is produced. It was unwanted. This cell has produced an ectopic firing because this time this cell was not stimulated by normal pathway. It auto-fired, right? And we say this is an ectopic firing, unwanted firing, irritable firing. Is that right? Then there are other things also which lead to cationic loading. Another classical example of cationic loading is, okay, you will tell me. You know, we say the people who have ischemic heart disease or angina or myocardial infarction, we keep on telling these patients that they should not be mentally stressed, they should not become too excited, they should not become too much emotional. Why? Because when they become emotional, when they become excited, when they become physically too active, they load the cation in the cell. Question is that how? Let me tell you. For example, this is a patient who has already ischemic heart disease. Due to ischemia, some cells are already loaded with cations. At the top, they become angry or excited, they put more cations. How? When you are angry, you will release adrenaline. You know it. And adrenaline will bind with the receptors here. You know, heart has beta 1 adrenergic receptors. So when adrenaline will bind here, when patient with heart attack, if they become angry or excited or tense, they release adrenaline. This adrenaline will bind with the receptors, and these receptors will stimulate a protein inside the cell, which is called G stimulatory protein. This G stimulatory will stimulate adenylyl cyclase, and this adenylyl cyclase will convert, yes please, ATP into cyclic, yes, AMP. Cyclic AMP will stimulate an enzyme called adenylyl. Oh my God, this is adenylyl cyclase. Cyclic AMP will stimulate protein kinase A. You are young man, your memory should be better than mine. Listen, Adrenaline stimulates adrenergic receptor which stimulate intracellular, G stimulatory which stimulate adenylyl cyclase which convert ATP into cyclic AMP, more cyclic AMP stimulate protein kinase A. One of the function which protein kinase A do, that they phosphorylate some of the calcium channels, and when these calcium channels are phosphorylated, more calcium will come in and cell will become further loaded with cations. So whenever you shoot adrenaline in your body, whenever such patients become angry or excited or emotional, right, adrenaline is going up. When adrenaline level is going up, it is basically loading the cations in myocardial cells. Of course, when they are loading the cations in myocardial cells, resting membrane potentials start fluctuating, undulating movement, and by chance if it start hitting the, what is this, threshold, it auto fires. This time now ventricle will not be under the control of SA node. Maybe if this is an irritable cell and it repeatedly fires because it is loaded with cations, that will lead to dangerous tachyarrhythmias in the left ventricular. Okay, this arrhythmia will be in the left ventricle or more on the right ventricle more. Remember, both ventricles are electrically connected. There is no partition in between them. So it will be biventricular arrhythmia. So simply we call them ventricular tachyarrhythmias, right? Now, we were discussing that let's suppose this cell is irritable. This cell is loaded with cations, maybe due to ischemia, or maybe due to hypoxia, or it may be due to inflammatory mediators, or it may be loaded with cations due to adrenergic crisis. So whatever the reasons, now it can fire automatically. How the activity of this cell will be displayed on ECG? Let's have a look. Suppose this is normal ECG pattern going on. Now look, at this particular moment, this pathological cell has fired. When this pathological cell will fire, it will not wait a stimulus to come from the SA node. It will auto fire, and when it will fire, the current which is coming out of this cell, this will not pass through normal conduction pathway, this will pass through a pathological pathway, right? And when this current is passing through pathological pathway, so that will make a pathological vector there, not a normal vector. So naturally the QRS complex will be abnormal. This is an abnormal QRS complex. It's wider. Why it is wide complex? Simply because that this is abnormal ectopic focus, and current which is spreading through this is not passing through normal high velocity pathway. So it's through moderate velocity, so it has to be wider, number one. Number two, that it has abnormal morphology, the reason being that current is again not coming through bundle of His and making a normal vector, right? For example, normally a vector, major ventricular depolarization is directed like this, but in this pathological condition, it may be directed like that. So naturally, what really happens, that your QRS complex will be of abnormal morphology. But if it gives only one fire, after that again, normal ECG pattern will re-establish. A normal ECG pattern will re-establish. And then, if you really look at the tracing, you may find another abnormal activity. Now, this type of abnormal firings, this one or that one, these are called ventricular premature beats. Ventricular premature beats. We simply call them VPBs, ventricular premature beat, because this ventricular ectopic focus fires before the normal beat come, right? They prematurely fire. So we call them ventricular premature beat, or other name is ventricular systole. Is that right? Now, If they are occasionally coming, they are not considered dangerous. But if they start appearing very frequently, then it's a dangerous sign, right? So if sometimes what happens that when normal ECG pattern is going on, a run of ventricular premature beats appears. And then again a normal pattern start. Now in this particular case, what we really say that there is one ectopic focus. Attention please, look here, all of them have same morphology. So one ectopic focus has fired many times repetitively. But here you say this morphology is different and that morphology is different. It means this is a different ectopic focus and that is a result of a different ectopic focus. Is that right? But here one ectopic focus has given multiple runs. So if it is really more than 120 beats per minute, and so then we may call it, yes, what do you call it? Ventricular tachycardia. Run of ventricular tachycardia. So we can say that if ECG pattern you continue studying, right, then what may happen that normal ECG is going on. Now I will make gradually more worrisome changes in ECG. Here there is 2 abnormal firing, what is it now? Ventricular tachycardia. This was ventricular premature beats, this double fire, then it is ventricular tachycardia. Then you look here. What is this? Yes, you will tell me. What is it? This is called ventricular, yes please, flutter. This is curved wave. This is called ventricular flutter. Ventricular flutter occurs when one focus may start firing and driving the ventricle so fast, somewhere between 250 to 350 electrical stimulation to ventricle per minute. So this is called ventricular flutter. But remember, if ventricular flutter continues for significant time, if ventricular flutter continues for significant time, then heart mechanical activity cannot follow so fast electrical activity. This is showing the fast electrical activity, flutter activity, but mechanically heart failed to pump. So it means if flutter continues for longer time, then naturally cardiac output will dangerously drop. When cardiac output will drop, then multiple hundreds of areas of severe ischemia will appear in the heart, and every area will start firing on its own. And when hundreds of the areas start firing simultaneously, we say there is onset of ventricular fibrillation. Again, let me repeat. When ventricles are undergoing fluttering, electrical flutter, it means that even though electrical activity is around 300, but there is no mechanical activity. So naturally cardiac output is not there. So coronary flow will stop, and multiple hundreds of the areas of severe ischemia will develop within the ventricle. And if all areas start firing automatically, then it will become ventricular fibrillation. Now let's see the difference between flutter and fibrillation. Usually in flutter there is 1 or 2 centers which are firing very rapidly. But in ventricular fibrillation, there are many centers, many ectopic foci which are firing very rapidly. And in case of flutter, then naturally, it will become like little baseline fluctuations, and then what is it here? What is it? It is death, right? Because flutter has left to the ventricular fibrillation. What is it here? Ventricular fibrillation. And ventricular fibrillation, if you don't treat well and rapidly, then it may lead to flat line, no electrical activity in the heart. Is that right? That may lead to death. So can you recognize these 4 patterns? That if you look at ECG, where are the VPBs? Can you see a run of ventricular tachycardia? And whenever there's sinus movement like this, what is this? Ventricular flutter. And if it becomes fine oscillations, what is this? Ventricular fibrillation, right? And if you fail to control this, then of course, or fail to revert it, right, patient may go to straight line. So this was some basic idea about the ECG and cardiac arrhythmias, right? It was very, very basic idea, not advanced studies. When we'll study for step 2 and step 3, then we'll talk advanced study about this.